Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners. Welcome back to another episode. Today, we are talking about all things antiarrhythmics and anesthesia, what you need to know for boards, what you need to know to provide a safe anesthetic, all of these things. Let's talk about antiarrhythmics. So this first section we're going to talk about is this Vaughan Williams classification. And this is a way that our antiarrhythmics are classified based on where they impact the cardiac action potential and the ion channels associated. So that is where this Vaughan Williams classification comes from and what we're going to talk about today. So basically what I want you to know is class 1 are sodium channel blockers. So class 1, sodium, and they slow conduction in those fast response tissues, so that atrial and ventricular myocardium. They have subclasses, right? They have A, B, and C. So let's see. 1A is a moderate block. So this is our procainamide and our quinidine. 1B is a weak block. So lidocaine, mexiletine, those are our weak block 1B classification for our sodium channel blockers. And our C is a strong block, flecainide and our propofenone. Okay, those are our 3 classification subclasses within our class A, within our class 1, which are our sodium channel blockers. For class 2, these are our beta blockers. These are the sympathetic dimmers, right? They slow AV conduction. We know a lot about beta blockers. We've talked a lot about beta blockers. They slow AV node conduction by blocking beta-1 receptors. Again, talked about it a bunch on this podcast. Examples: metoprolol, esmolol, propranolol. You know this from undergrad, pharm. That's an easy one. That is class 2 in this Vaughan Williams classification. Class 3 are our potassium channel blockers. These are our repolarization extenders. They prolong that repolarization. So, for example, these are our amiodarone, our sotalol, and our dofetilidine. So a way to remember this is class 3 keeps K in the cell longer. So class 3 keeps K in the cell for longer. Class 4 are our calcium channel blockers, the AV node chillers. Okay, we've talked about in other lectures about our non-DHPs. Those are our verapamil and diltiazem, and those slow that AV nodal conduction. A couple of our unclassified antiarrhythmics are our adenosine, our digoxin, our magnesium. So these are ones we're going to go into for boards purposes and for anesthesia importance. We're going to go into them. They basically said we refuse to fit into your categories. We got our own thing going on, but we are considered antiarrhythmics as well. So again, let's talk about the mechanisms of actions and side effects, which are kind of all-inclusive to understand these medications. And again, memorizing is not what we do here. We want to understand what's going on so that we can commit it to long-term memory and not data dump what's going on. So instead of listing each class in isolation, we're going to interleave them together to hopefully make those synapses fire and remember it better. So class 1, again, are our what blockers? Sodium channel. Class 1, sodium channel. The mechanism is it slows phase 0, depolarization, and you have slower conduction. The side effects of doing that, so if you're slowing phase 0 and depolarization and resulting in slower conduction, what side effects are you going to have? We have negative inotropy. The CNS effects be like lidocaine. Anesthesia angle. If a patient is on a class 1 drug, avoid other agents that prolong QT, which would be methadone, droperidol, prolonged QT. The main medication I think of is our Zofran, right? If patients have QT syndrome, prolonged QT syndrome, we wouldn't give that as well. So thinking about how our regular medications may impact these antiarrhythmic drugs. The anesthesia angle for beta blockers or our class 2 antiarrhythmics is they blunt our response to direct laryngoscopy. Do not stop them abruptly, however, because you may have that rebound tachycardia and therefore ischemia, which is why we want our patients to take them on day of surgery to decrease MI risk. Expect exaggerated hypotension with propofol. So that's what we expect with our beta blockers at class 2. This is where we're going to dive into our class 3 antiarrhythmics. These are our potassium blockers. So the mechanism is that they prolong repolarization. So you're going to have a longer QT, longer refractory period. So those side effects to that, because of that prolonged QT, you have a risk of torsades, right? For amiodarone, you have pulmonary fibrosis, thyroid dysfunction, liver toxicity, corneal deposits, and bradycardia. So with amiodarone and our volatile anesthetic agents, to talk about the anesthesia angle with our class 3 antiarrhythmics, with amiodarone and our volatile agents, we are going to watch for profound bradycardia and hypotension. We're going to avoid other QT prolonging drugs. So that is, like I said earlier, our ondansetron, our Zofran, droperidol, and methadone. Class 4 are our non-DHP calcium channel blockers. The mechanism for this is it blocks calcium in the AV node, slowing the conduction. The side effects for this would be bradycardia, which makes sense because we're slowing that AV node and lowering conduction, hypotension, AV block, and negative inotropy. With the anesthesia angle with our class 4 antiarrhythmics are an additive hypotension with propofol and volatiles, avoiding beta blockers in unstable patients due to the side effect of potential severe bradycardia with the two together. Let's talk about our unclassified drugs that just don't fit into our classification system, but here they are: adenosine. Adenosine slows AV node via hyperpolarization. So the side effects of this is that feeling of impending doom with adenosine and potential bronchospasm. For digoxin, this medication increases vagal tone. So the side effects would be potential AV block, scooped ST segments, and we have to be watching for toxicity with what type of electrolyte imbalance. We know this from undergrad, hypokalemia, right? If they have a low potassium with digoxin, we are worried about dig toxicity. All right, the last unclassified antiarrhythmic that we're going to talk about is magnesium. This is the treatment for what rhythm in the operating room? Torsades, right? The side effects of magnesium are hypotension and flushing, and there are longer-term effects, which if you work in labor and delivery or ever have, we know that patients on MAG lose those deep tendon reflexes, right? But for our purposes, the side effects are hypotension and flushing with magnesium. So let's connect what these drugs do to you in the operating room. So the heart is an electrical grid, right? These antiarrhythmics tamper with this wiring that's going on. You, the anesthetist or anesthesia learner, eventually anesthesia provider, add anesthetics on top of this, which also tamper with this wiring. So let's go class by class and talk about what our anesthetic considerations should be for each antiarrhythmic. So class 1 is conduction slowing. We are at risk for a wider QRS and a risk for heart block. So during anesthesia, avoiding high levels of volatile agents, avoiding drugs that prolong PR or QRS. Class 2 is our bradycardia risk. So class 2 is what medication? Beta blockers, right? So our risk is bradycardia, severe bradycardia with propofol and opioids. So we're really careful with titration and dosing with that. During anesthesia, pre-induction glycopyrrolate may be helpful. Having atropine and ephedrine ready to go just in case you may need a little bit of support. They protect rather from ischemia. So not stopping them preoperatively is really important anesthetic consideration for our beta blockers. Class 3 are our potassium channel blockers, and these cause prolonged QT. That's a risk. And torsades. So during anesthesia, with our class 3 agents, we want to avoid ondansetron, Zofran, droperidol, methadone, high-dose sevoflurane, correcting our magnesium, our potassium, and our calcium, making sure that their electrolytes are balanced. Class 4, it has an AV block risk, right? So during anesthesia, we would expect exaggerated hypotension with propofol, a refractory bradycardia if combined with beta blockers, but great for controlling SVT, but watch your blood pressure, right? So I hope that summarized our anesthetic considerations for each of these medications. Let's go into the next section, which is the monitoring of these patients. So if someone is on antiarrhythmics, we monitor like this. So electrolyte imbalances turn antiarrhythmics into proarrhythmics. So we want to make sure our electrolytes are balanced. Lastly, second to last, hemodynamics. Our hypotension can occur from our classes 2 and 4. Bradycardia can occur from 2, 3, and 4. So we're watching hemodynamics as one does as an anesthesia provider always. And this, for real, this time, lastly, drug interactions. Many interact with anesthesia drugs, so always pull up the chart. Amiodarone plus volatile agents can result in severe hypotension. So we're keeping that in mind and monitoring appropriately. Let's run through again a couple of case scenarios to get that active retrieval going for these meds and commit it to long-term memory. Case number 1, our patient is on amiodarone. Okay, what issues do we expect with a patient on amiodarone? We could expect bradycardia. We could also expect QT prolongation and hypotension, right? Our plan is to limit SIVO, so making sure that we're giving the patient what they need and not anything above that. Use direct-acting vasopressors, right, like phenylephrine, because ephedrine is an indirect-acting vasopressor. Avoiding QT prolonging meds, and keeping magnesium and calcium normal, right? So those are our anesthetic plan considerations for a patient that is on amiodarone. Case 2, the patient is on flecainide. So expected issues with a patient on flecainide would be a widened QRS and negative inotropy. So our plan would be to avoid other conduction slowing agents using lower volatile concentrations and consider TIVA if unstable. So those are all considerations with our patients on flecainide, for example. We have one more case study that we're going to talk about. This is a patient that's on metoprolol and diltiazem. So with these 2 medications, our expected issues would be severe bradycardia and potentially AV block, right? We're always thinking about worst case scenario in anesthesia, and this would be it, severe bradycardia and AV block. Our plan would be to have glycopyrrolate, ephedrine, and epi ready. And obviously we have all of these things in the Pyxis. We know they're ready, quote unquote. But depending on the patient scenario, you may want to have them on top of your Pyxis ready to go so you can grab it very quickly, have epi diluted down to whatever you may want, 10 mics per, 5 mics per. I worked in a hospital that had 5 mics per. It was Peds hospital, but just from pharmacy in the drawer, which was so nice to have. Just a little bit of epi when you need it is great. Avoid high dose of opioids and keep them normovolemic for those patients on metoprolol and diltiazem simultaneously. So let's lock this in. I'm going to ask some retrieval questions. Which class prolongs QT the most of drugs? Everybody said class 3, right? And our class 3 drugs are our potassium channel blockers. Next question is, which class shows AV node conduction? A couple of them. Class 2 and class 4, right? So our beta blockers and our calcium channel blockers both slow AV conduction. Which antiarrhythmic has the most side effects? Amiodarone. If you said all of these out loud, I'm really proud of you. And if you answer them correctly, even more proud of you. If not, you'll get them next time. And you'll remember it next time. So now I'm going to give you one last piece of advice like I do on this podcast every time, since we summarized these antiarrhythmics pretty quickly today. But let me think of one first. What is something? I guess I'll get fluffy today and just say that. Okay, one piece of advice or encouragement I have for an anesthesia learner today is to find someone to lean on throughout your anesthesia training. Someone that understands, whether that's somebody that's older than you. My program did senior and junior buddies, and we had that person to talk to, ask questions to, lean on for support. It's never weak to ask for help and to lean on somebody else. I think that it's such a strength to be able to be humble enough to do that. And that is my encouragement to you. My mom had been a CRNA for 15 years when I went through anesthesia school, and I don't know what I would have done without her continual guidance and support and the mentors that I collected in my pockets until this very day. I'm so grateful for them as well. So that is my goal for you today, is to find a mentor or someone to lean on throughout your anesthesia training and seek out for help when you need it, because we all need it from time to time. So that's it, my favorite learners. We'll see you next time. This was a short and sweet episode, but I hope you learned something about the antiarrhythmics.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.